I'll be presenting a talk which was originally presented by Dr. Carmen Bergom at the 2021 SABCS, which is Life After Breast Cancer, the State of the Heart. So cancer and cardiovascular disease are the most prevalent diseases in the developed world and are fast rising in the developing world as well. And evidence increasingly shows that these conditions are interlinked through common risk factors. And also anti-cancer therapies can cause a wide spectrum of short and long-term cardiotoxic effects. So, which is why the scope of cardio-oncology is wide, and it includes prevention, detection, monitoring, as well as treatment of cardiovascular toxicity, and also coming up with cardioprotective measures to ameliorate the side effects of treatment toxicity. So we have here, so just to, before beginning, just to summarize the known cardiotoxicity of the common breast cancer therapies. We know these figures well, doxorubicin-induced and trastuzumab-related cardiotoxicities, as well as cardiotoxicity of breast cancer radiotherapy, the famous Darby et al., which says 7.4% increase of major coronary events with mean heart dose increase by a Gray. The studies we have here today are three. Two are subset analysis or cohorts of the Pathways Heart study, and one is subset analysis of the phase 3 SAFE trial. Moving on to the Pathways Heart study, the Pathways Heart study is an ongoing study where women aged 21 or more with first diagnosis of invasive breast cancer who are members of the Kaiser Permanente of the Northern California, which is a healthcare company, are enrolled. And the questions that the Pathways study hopes to answer are many. So mainly they include, should women with breast cancer eat a particular diet? How much and what type of exercise is best? Are there particular dietary supplements? What role do social and friendship networks play? So these are some of the questions the Pathways Heart study aims to answer. They have almost 50 publications since 2008, and what was presented this year at SABCS is 2 more. So I wouldn't talk much about this the first one, because it was already described in detail by Dr. Ashi Agarwal. So I would quickly summarize the first one, which is the cardiovascular disease risk of breast cancer therapies by body mass index, where they tried to stratify the risk of certain chemotherapy drugs, the cardiovascular disease risk as well as stroke risk, and it was classified according to the body mass index. And as we saw earlier today, the conclusions were there: certain chemotherapy drugs and left-sided radiation may confer a higher CVD risk for breast cancer survivors with normal weight. And there was a paradoxical conclusion there, which was that certain chemotherapy drugs may lower stroke risk for breast cancer survivors with obesity, which they are attributed to something called as the obesity paradox, which is outside the scope of this talk, but it just is something that overweight and obese cancer patients have better cancer survivals for diverse cancers. And this apparent paradox is explained by various methodological limitations, which may make for an interesting reading. The second of the Pathways Heart study, which was presented this year, was the development of cardiometabolic risk factors following endocrine therapy. So we know that endocrine therapy is associated with certain cardiovascular disease risk in breast cancer patients, in breast cancer survivals, and this may be associated with developing cardiometabolic risk factors such as diabetes, dyslipidemia, and hypertension. So all the known studies compare the risk factors of tamoxifen versus AI, but here they compared the risk factors in tamoxifen and AI users versus women who did not use endocrine therapy. And then they stratified it by menopausal status. So the methodology was, as described earlier, the women who were enrolled between 2005 and 2013, and they used various methodologies to identify the cardiometabolic risk factors. The statistical analysis was Cox proportional hazards adjusted for baseline risk. And out of 14,942 patients, 24.9% were premenopausal, and out of which 27.3% used tamoxifen, and 53.5% did not use any endocrine therapy. Their results were that neither tamoxifen nor AI use was associated with risk of developing diabetes, dyslipidemia, or hypertension. And just walking you through this. So as we see, they mainly saw three parameters. So they're mostly eco-related parameters. The 3D-LVEF and the global longitudinal strain, which are all eco parameters. So the 3D-LVEF, just a second. Sorry. Yeah, so here we saw that AI users had a higher risk and tamoxifen users had a lower risk of developing dyslipidemia. And for diabetes and hypertension, there was no statistically significant association. So this was their conclusion. It is very important to note that these are abstracts and it is difficult to form conclusions or conduct a detailed discussion. There are many unanswered questions which the final paper may answer. Moving on to the third study, which is a subset analysis of the phase 3 SAFE trial. Several studies have evaluated cardioprotective strategies to prevent myocardial dysfunction in patients who receive cardiotoxic therapies such as anthracycline, trastuzumab, etc. However, the medical oncologists are yet to come up with optimal solutions like our cardiac shielding and deep inspiratory breath hold. So their search for the optimal cardioprotective strategy is ongoing. So the SAFE trial was a 4-arm randomized phase 3 double-blind placebo-controlled study conducted in 8 centers in Italy. So anthracycline chemotherapy is hypothesized to cause cardiomyocyte injury, and they proposed that angiotensin-converting enzyme inhibitors can prevent cardiac remodeling and reduce mortality in patients with cardiac dysfunction. So their objective was to see whether these pharmacological cardioprevention measures could reduce subclinical heart damage in breast cancer therapy in breast cancer patients treated with anthracycline-based chemo. And the 4 arms were the placebo arm, the ramipril arm, the bisoprolol arm, and the bisoprolol plus ramipril arm. And this particular subgroup analysis studied the impact of post-operative breast radiotherapy in the pre-specified interim analysis of the first 174 patients which they enrolled who completed cardiac assessment at 12 months. And again, these cardiac assessments were 2D echo parameters, mainly LVEF and global longitudinal strain. And they conducted univariate and multivariate analysis with variables including the treatment arm and other risk factors such as smoking, BMI, hypertension. So here you see that 3D LVEF changes from baseline to end of treatment in the bisoprolol containing arm had significant benefit in patients not receiving RT, which is a p-value of 0.009, in patients receiving right-sided breast RT with a p-value of less than 0.001, and to a lesser extent in patients receiving left-sided RT, whereas the global longitudinal strain changes from baseline were significant in the bisoprolol arm in patients not receiving RT, in patients receiving right-sided RT, whereas no benefit was shown in patients receiving left-sided RT, left-sided breast radiotherapy. So here again, we see that the 3D LVEF changes from baseline to end of treatment. So the bisoprolol containing arms had significant benefits. It is important to note that the only trial arm which was associated with GLS worsening was the placebo arm. Logistic regression also confirmed that the placebo arm had a significant higher risk of GLS worsening. So to conclude, cardioprotective pharmacological strategies are well tolerated and seem to protect against cancer therapy-related LVEF decline and heart remodeling. And as I mentioned, the only significant parameter which worsened was in the placebo arm, thus confirming the crucial role of cardioprotection in patients receiving chemotherapy. anthracycline-based chemotherapy. So to conclude, these 3 studies added to our knowledge of ways to improve treatment, surveillance, and cardioprotective therapies. Thank you.